Hello, everyone, and welcome to yet another episode of the IJA podcast. This is me, Gayatri.
And this is me, Rashmi.
And together, we'll be taking you through some interesting aspects of the February issue of the journal.
And like always, we will begin with our editor-in-chief, Dr. Rakesh Gar.
Dr. Rakesh, hi.
Hello, Gayatri and Rashmi. Thank you for taking this podcast forward, and thank you so much.
So what is happening in the IJA world, Dr. Rakesh?
Absolutely. I think IJA is the face value of academics, and with the support of each one of you, each one of the authors, reviewers, and editors, I'm sure it is getting worldwide popular. And also it is giving a lot of new insight into the ongoing research across the world. So it is truly a global journal, and I'm sure that with this new research coming up from across the globe, I'm very sure that our clinician, our readers would be benefited from it. We have a very high class articles. In scientific writing, we say robust quality maintained articles. And I'm sure that, in fact, our patients will also be benefited from it.
Yes, I was just going through the article this time. We have a lot of global authors as well in this edition, right?
Absolutely. I think the IJA belongs to the global community. It is a global journal with the impact factor of 2.9. And I'm sure with the quality article coming from very good researchers across the globe, this journal will be a huge academic compendium for various research in future as well.
So all in all, it's safe to say that you're a happy man this year.
I think it's a happy IJA and happy reading IJA for all of us. You're absolutely right, Rashmi. I'm a happy man, but this journal belongs to each one of you. Each one of you, it's your journal. You take it forward and come up with good articles. And I'm sure even in today's past podcast, as anesthesiologists, we are very fond of playing with the drugs. Some of my teachers used to tell me, when you practice anesthesia, it is not one setting on one drug. It is something like you have to play with every move in any of the sports activities. Maybe something it also applicable to our practice, because we use an armamentarium of equipments. We use a galaxy of drugs. And I'm sure today's podcast, when we talk of drugs, the researchers who are coming in today's podcast will highlight why and how these drugs can be beneficial in various combinations. And I'm sure we need to learn them and bring out the best benefit out of these drugs into our clinical practice.
Dr. Rakesh, how do you think this month's edition is much more different compared to your other editions?
Absolutely. A lot of new articles and systematic review and meta-analysis has come up. And when we say the meta-analysis, they are the highest level of evidence, because it comprises of the various research which has been published globally. And two very interesting meta-analysis has been there, which talks about the pain management, which talks about the use of drugs also. And I'm sure that going through it, we can always improve onto a clinical practice. And simultaneously, we also have, when we talk about young budding anesthesiologists, they are looking for the careers. And there is one special articles in which we'll be talking about, which we have published, which is about the career in anesthesiology, what the youngsters are looking for.
I'm sure all of them are very excited about this month's edition.
So Dr. Rakesh, like you were saying, we have 3 articles that we have selected this month, and we're very excited to share and converse with the authors. So Rashmi is going to start with the first article.
Yes, before I tell the title about the first article, let me introduce Dr. Shaktirajan Panneerselvam, a professor of anesthesia from JIPMER, Puducherry. His article is about comparison of airway collapsibility following single induction dose ketamine with propofol versus propofol sedation in children undergoing magnetic resonance imaging, a randomized controlled study. Dr. Shaktirajan, welcome to the podcast.
Yeah, good evening. Thank you for invitation.
So moving ahead, just a couple of questions. Could you describe like the key aspects of your study, sir?
So the key aspects of the study, one, it involves the pediatric population. The pediatric population is the one we need a research to. We cannot extrapolate what happens in a general population to pediatric population. We need studies, especially children undergoing magnetic resonance imaging. They require a deep sedation level, which pose a considerable risk of airway collapse. So this study aimed to prevent the airway collapse by adding a single dose of the ketamine along with propofol, which is the most commonly used potent anesthetic agent world over. So the purpose is to study the effect on ketamine on airway collapse. We measured the airway collapse by measuring the airway dimensions based on the MRI studies, which was feasible because the children were undergoing MRI of the brain in our study. So
I'm
we
sure
found that the single induction maintained the airway better than single induction ketamine with propofol maintained the airway better than propofol alone. And I hope this may improve the safety in future.
Yes, sir. Of course, like the safety aspects are a main important thing when it comes to pediatric participants. What considerations were made regarding the ethical aspects, sir?
Yes, children are a vulnerable population, so we should be able to ensure the justice and beneficence when you devise any study in pediatric population. In this one, the first the principle of do not harm. So what we did is we ensured that there is no new methods or new things which is non-standardized ways. We avoided it. We ensured that the safety is mentioned. Safety is adhered by ensuring a standard monitorings and presence of a trained or experienced anesthesiologist while doing the study, and informed consent was taken. And as the children in our group are 1 to 6 years, very small children, they may not able to understand regarding the assent is a difficult part. That's the one challenge. So we just explain the procedure to them in a way so that they agree to the procedure. And most of our children are neurodevelopmentally delayed patients who undergo say MRI for the evaluation of the brain. So that's one challenges of getting patients assent. But we got an ethical approval with the parents' consent. Right. There's the challenge is these aspects only. But we ensure that the safety is adhered throughout it, and we placed certain rescue protocols in the event of airway collapse, what to do. Right. So the rescue protocols were in place and they were strictly adhered.
I'm sure it was a very risky task, doctor. Why did you choose these drugs in question?
We know that when we choose an agent like propofol, which is more potent, the more potent the drug, the faster the onset and the rapid the recovery. But the issue with this propofol is that airways collapse with the increasing dose may most of the time the MRI requires a noisy environment. We require a patient to be deeply sedated. So in small children, necessarily 1 to 6 years of age, as in our group, there is a risk of airway collapse. So we know that synergism or additives may each of two drugs will help each other's. It may beneficial reduces the risk. This principle we know that. So based on that, we have added a single dose of ketamine. And the ketamine, of course, maintains the airway patency. So this may be helpful to reduce the propofol requirements. So thereby we postulated the theory that it may improve the airway patency. That was evident in the MRI. We may just what we obtained in our study, and we compared with the standard arm, and that we proved that yes, single dose is safe. Yeah.
Right, doctor. Are there any concerns with the ketamine infusion? And also, do we know about similar airway collapsibility effect of dexmedetomidine?
Yes, we know that dexmedetomidine is an emerging drug in this field, especially pediatric sedation. But the issue is that the dose requirement is mostly goes up to 3 microgram per kilogram, which is usually higher dose, which may there is a problem with this dexmedetomidine. There's a risk of airway. The airway is maintained. The problem is the risk of cardiovascular side effects. Those studies proves that there is no increased side effects. But what if we in an Indian scenario where there is a increasing number of patients we need to anesthetize, and one a day, in a single day, we have to give 10 to 12 cases within the stipulated time, right? These drugs will take a time of onset and time of recovery, which is delayed with the reduced resources. These aspects also we have to consider because dexmedetomidine induction time is longer and titration is difficult, and lack of infusion pumps in an Indian scenario, that all makes these impedance to the dexmedetomidine in this one. Of course, I agree with that. It maintains airway patency in children. That has been proven. Yeah.
Absolutely.
So I saw that you chose to dilute propofol in dextrose. Was there any particular reason you decided to do that?
Yes, there are two reasons. One reason is highly concentrated propofol usually is painful to inject. And children, as you know, when you start induction, they move, they dislodge the monitoring devices. It's very difficult in a MRI environment. So that one reason. Another reason is that when you dilute, the flow rate can be easily adjustable. When the flow rate is, then the dilution reduces the risk of, when you give a faster, dilute the drug and faster, despite that, there is a less reduction in the blood pressure. The blood pressure is maintained. One is to prevent the pain on injection and to maintain the blood pressure and to adjust the flow rate easily, the drugs were diluted.
Okay, all right. Oh, that is very interesting.
Sir, I'm sure there were a lot of unexpected results and challenges which were encountered during the process. Could you mention a few?
The unexpected challenges, what we have, there was no much unexpected challenges. Yes, there are the quantification of capnography is extremely difficult. We may get a qualitative as the patient's capnography trace was just placed around the mouth area and it will get diluted. So we may get some interruption in the capnography. So we have to ensure that the capnography tubes are very well secured during the MRI. So especially the inside the child is moving after positioning the child. And of course, there is a concern of respiratory monitoring is the one challenge. So we need a little experienced person there to monitor the respiration.
So you say that's like you monitor the chest rise in the kids, like any special method to do this?
Yes, observing the chest rise inside the MRI, it's really one. We should ensure there is adequate light. Of course, there is inside the console, there is adequate light sources there. And they should be covered with blankets so you may not, especially in small children, you may not able to observe. What we do in our institute, we used to keep the face mask, the clear face mask, anesthetic face mask on the chest above the blankets. And we'll see the movement of the face mask up and down. Right? Thereby, we know that the child is having a breathing. Whenever this movement is reduced, we have a close. We always sit beside the patient and we closely monitor. We don't come out of it. That's a protocol we follow to ensure the close monitoring of the child during MRI. That's a
very nice method,
yeah.
sir.
Yeah. Because we've actually, I think we used to learn that we can use a paper to keep it on the chest of the patient to look at chest monitoring. But when I do with very small babies, it's very difficult to see the paper moving.
Yeah, they're covered with blank.
Mask is there. In case of any obstruction, we keep the mask attached to the circuit and we can give immediately.
Okay.
So dual purpose, yes, sir.
We need not to search for the mask. And this appropriate mask, we should keep it on the child's chest. So there are children of 1 year, one mask, and 8 years to have a different mask. So it improves the safety aspect. That's how we did
that's very nice.
Correct, sir. So all in all, in practical terms, how do you think this research influences the anesthesia protocols for pediatric sedation in MRI settings?
Yes, inclusion of a ketamine is a routine practice, but most of the time the ketamine is mixed with the propofol as a continuous infusion for prolonged. What we observed in this practice, there is a prolonged recovery time and kind of emergence deliriums, that part is increasing. So that propofol requirement decreases and the patient's airway is maintained. What we observed in our institute is there's a turnover time getting prolonged and the limited resources of 4 beds in the postoperative. So we need to transfer oxygen sources are 2. So we need to ensure that we have to turnover also to increase. So we ensure that single dose didn't prolong the recovery time, meantime maintain the airway patency. So this kind of a single dose technique possibly may be included in the protocols. So to ensure that safety as well as the efficiency of the workplace in any of the institute. That's we suggest.
Thank you, doctor. A lot of our queries were answered.
Thank you very much. Thanks a lot.
Next, we have Dr. Chandni Sinha, Professor at Department of Anesthesia from AIIMS, Patna. Their study includes comparative evaluation of nebulized dexmedetomidine versus fentanyl for the treatment of post-dural puncture headache in parturients after cesarean section under spinal anesthesia, a randomized control study. Welcome, ma'am.
Thank you.
Ma'am, what led to the initiation of this study and what gap in existing research were you aiming to address by comparing these two nebulized dexmedetomidine and fentanyl for PDPH in parturients?
Thank you, Rashmi. Firstly, I would like to thank Dr. Rakesh Gar for getting me here. Okay, so as all of us know, PDPH is a fairly common problem encountered after cesarean section, which interferes with the patient's daily activity, especially the care of the newborn. So though we have plethora of drugs and interventions used for PDPH, there is limited success in using them. Actually, we have lots of research articles which have been coming up, but majority of them focus on various interventional techniques for this problem. Hence, we wanted to study the effect of a non-invasive technique, that is nebulization, using various drugs, that is dexmed and fentanyl, in pain relief for these patients.
Doctor, how did you determine the appropriate dosage and administration regimen for the two drugs in the study? And were there any notable considerations in choosing this method of administration via nebulization?
Yeah. So there have been previous articles in which nebulized dexmedetomidine has been used, in which they have taken the dose which we have taken. And before we started off the study, we actually did a pilot study in around 5 patients in promising results. We used the same dose and we used the same regimen as we have mentioned in this study. And why this mode of delivery of drug? That is why nebulization, because it is easy to set up. We can do it in wards. Patient compliance is good. And also adverse effects is less with good bioavailability. That is around 60% in transnasal and around 80% in transmucosal.
Right, ma'am. So there are other studies on nebulized fentanyl, which seem to have chosen a higher dose of administration. Do you think that could have altered the outcome of your study? And did any of your patients have any side effects with such dosage?
Right. We used fentanyl at a lower dose. Usually the rest of the studies have mentioned a higher dose, that is 2 to 4 microgram per kg. But since we did not have any data in lactating women, we chose a lower dose, that is 1 microgram per kg. So in fact, actually, the effect, which is not so promising in the fentanyl group, could be attributed to the lower dose, and that could be one of the limitations of the studies. Talking about the adverse effects that we are scared of is hypotension and bradycardia while using dexmedetomidine. But fortunately for us, we did not encounter in any of our patients. The only thing that patient complained of was dry mouth, and that too in 3 patients.
Okay, ma'am. You seem to have an incidence of PDAPH of about 6.2% in your institute, which you have attributed to the use of the dura cutting needles. Like, what is the normal course of treatment you follow for these patients in your institute?
Okay, so we usually advocate supine posture, encourage oral fluid intake, use of analgesics like NSAIDs and paracetamol, and caffeine if required. Lately, what we have started doing, we have started adding dexmedetomidine with good results in these patients.
So you've now added dexmedetomidine to your PDPH management armamentarium.
Right. We have added.
And are you quite happy with the results?
We are quite happy. Actually, the pilot study itself, we had found promising results, and we have actually incorporated it in our day-to-day practice as an add-on, not as a standalone technique, but as an add-on to the various other pharmacological interventions.
Doctor, do you see this modality being added to the general recommendations for the management of PDPH in parturient patients?
Yeah, I do believe that eventually it would be added to the general recommendations for the management of PDPH patients. Lately, there have been few other articles. The most notable one is by Movafi et al., which was published in Journal of Anaesthesia, which studies the effect of dexmed in PDPH patient, and they had done transcranial Doppler, and they have said that dexmed actually has cerebral vasoconstricting effect. So this study also proves that dexmed is good, and eventually studies will come up with larger samples be added to the general recommendations in the long run.
Thank you, Dr. Chandini. Of course, PDPH is day in and day out a common issue, and adding your insight through this article will help us a lot.
Thank you.
So in choosing the next article, we decided to move a little away from the randomized controlled trials, and we took this article because we thought it was asking a very important question. And to discuss that, we have the author of the article, Dr. Febrauary. She's a consultant onco-anesthesiologist at the Basavatarakam Indo-American Cancer Hospital and Research Institute, Hyderabad. I hope I got the tongue twister name of your hospital right, Dr. Vibha.
Yes, you did.
So we're going to discuss her article, which was published in the February issue, which is Career Opportunities and Guidance Among Early Career Anesthesiologists, a questionnaire-based cross-section survey. So Dr.
Sure.
Vibha, welcome to the podcast.
Thank you. Thank you for inviting me here. And I'm quite excited about being on the IJA podcast.
Yes, I must congratulate you on this brilliant article. And I think it's such a relevant topic. And I'm glad you thought of addressing this.
Sure.
So before we go on to the proper discussions, I just want you to describe to our listeners what you mean by early career anesthesiologist and what this survey entails.
Sure. So this survey is about early career anesthesiologists. And what we try to see is about the career opportunities that are available to them, the preferences regarding career that they make, both while pursuing further education as well as selecting job options. And finally, we also wanted to look at the career guidance that they possibly could have received. Here, the phrase early career anesthesiologist actually means that we included the anesthesiologist who had finished their graduation in less than 5 years. And we thought that this time period is crucial for them to take decisions which would actually affect the rest of their career.
Okay. So I recently came across this article in the ASA Daily News column, which said that in the United States of America, the anesthesia residents, the number of anesthesia residents who chose to move into fellowships were double the rate that was seen in the year 2017 when compared to that we're taking in 2020. And in your article also, we see a similar trend in India with about 63% wanting to pursue further academic progress. What are your thoughts on this trend?
As you said, that our survey did show that around 2/3 wanted to pursue further education. And I think that this trend is good for two reasons, both for the young anesthesiologist as well as for the specialty. For the young anesthesiologist, I feel, which I think you would also agree, that there is a lot of discrepancy in the quality of training across various centers in India that are having MD and DNB curriculum. And pursuing another course after they finish their graduation actually gives them an opportunity to work in a different center, to do more focused work, to gain more knowledge as well as skills. Regarding the specialty, I feel it is good because it allows growth of the specialty. When there are a group of people wanting to work focused in that specialty, it not just fosters research, but also improves the quality of care in that specialty. So I think it's a good trend.
Yeah. So, but what do you think has brought about this change? Do you think the thought is that doing a fellowship or super specialization increases your brand value in the job market? Or do you think there's a genuine interest in honing their skills in a subspecialty of their liking?
Well, we were also curious about it, and we did have a question in the survey that addressed this. And around 2/3 did mention that they choose to pursue further education, mentioning a pure academic pursuit. However, one cannot really rule out bias here. And this is something that is described as social desirability respondent bias, which means that the respondent would want to answer in a socially desirable manner. So there is a possibility that many would have said that, but I feel that at least 1/3 did mention that they did this for the monetary gains. I think that, yes, doing an additional degree or a course does add to some amount of monetary gain, but it also helps in improving their exposure, their experience, also their social network that actually enhances their possibility of getting a better job.
I like the term social desirability bias. I think we are all, we all do that, right? Whenever we get a survey question, we like to sound very, important and correct. All right. So, yes. So it was also interesting. I was just reading, and it was interesting to note that while most of them prefer to pursue higher studies abroad, when it came to work, however, they chose to come back to India. Well, why do you think that is so?
Exactly. So that's exactly what we were wondering. However, I don't have an answer because we haven't addressed the question specifically. But just trying to speculate, I think studying abroad is a way that they think that they would get better skills, better knowledge. Also, some of the responses that they have mentioned why they would want to study abroad in the survey are that they expect better quality of training. They have also mentioned less working hours, better pay, and better research opportunities. But when it comes to working in India, I feel that I think India is also a growing economy, and there are possibly more job opportunities. Some of them might have family or any other liabilities. And of course, you would agree that the support system is definitely better in India.
So I also saw that you had a question on how they rated the quality of training in India when compared to training abroad.
Yeah, and it was quite heartening to hear that because only around 15% felt that the quality of training outside India was better, while most thought that it was either equal, better, or at least better in a few centers in India.
Another detail that kind of piqued my interest was to note that more and more females are opting to pursue higher studies. What do you feel about this trend? Do you see something similar in the applicants to your onco-anesthesia fellowship as well?
Yeah, absolutely. I think the number of females applying for various fellowship courses are more as compared to males. And I think this basically is because there are more number of females who are joining the MBBS course. And I think this was out in one of the Times of India surveys a couple of months back. So I think it stems from there. However, I would also want to believe that men, after they finish their graduation, would want to join work, start earning, start setting up their families. And on the other hand, I also feel a little relieved that female are wanting to pursue courses. So they probably have a better support system at home, and that's quite heartening too.
Yes, absolutely. Yes. Yeah. I think even we are here doing all this because of the support system at home. So I think yes. All right. And then one last question before we wind up. The survey brings to the fore the stark lacunae in mentorship in anesthesia. What do you think are the scopes of establishing effective mentorship programs in India?
So I think that's a very, very important question that has surfaced from this survey that we all need to address. I think as a group, as a society, the ISA should also take cognizance of this. I recently read an article a couple of months back in IJA, which actually proposed modular curriculum for the anesthesiologist. And amongst the modules was, of course, included multidisciplinary knowledge, the technical as well as non-technical skills, but it lacked career guidance. Career guidance is something that is going to be required for our young anesthesiologists as more and more of these surface, as more and more of these courses in various specialities surface. I think they can be addressed in a very multifaceted manner, meaning it can be included in the curriculum, it can be as a part of lecture series, or even in IJA conferences at various levels. There can be special dedicated sessions. There can be support groups wherein people at various levels in a particular pathway are included. And probably the best one is one-on-one mentoring, which can be achieved through these support groups. So I think there are various ways of trying to improve the career guidance for these young anesthesiologists. And this is something that we definitely need to work on. Lots needs to be done in this area.
There are some institutes also, I believe. I think CMC Vellore has some kind of a mentorship program, and but that's for the MBBS students. Is that it?
Yeah, so they do have fosters, meaning foster parents. When MBBS students join in, they are assigned to faculty who would take care of them. Basically, also the social aspects are taken care by foster parents. However, they do not have these for the various graduate courses. Here, what we are really looking at is if someone wants to choose a particular specialty, the person would be looking at a mentor who is, someone who is renowned in that specialty, isn't it? So this tagging of the mentor to the mentee is what really needs to be done. And maybe ISA as a body can take up this responsibility.
Yes, absolutely. Thank you so much, Dr. Vibha, for joining us at the podcast today. It was lovely talking to you.
Same here.
Thank you, ma'am. To conclude, our journey through this podcast is helping us gain a very deeper understanding of many concepts. I hope this podcast has sparked your curiosity and provided certain valuable insights. Thank you for joining us on this conversation, and hope you enjoy it as much as me and Gayatri are enjoying doing it. Stay tuned for much more engaging discussions. Until next time, keep learning and keep thriving. Thank you.